Hi, my name is Jason Chandler. I'm a hematology/oncologist at West Cancer Center, and I'll be doing a discussion today about hypercoagulability workup and management. So I'll get right into it. Okay, so I wanted to focus on different aspects. I was going to talk about just venous thromboembolism basics, including incidence, diagnosis, management. Go through some of the common questions that come up in consults with both starting and stopping anticoagulation and managing our patients in the clinic. And then the main part of it is the testing surrounding hypercoagulability, what to include, what not to include, and then rare tests, and then also a little bit about COVID. So the basics of deep venous thrombosis, which is one of the most common venous thromboembolism. For the rest of the talk, I'll just say VTEs. This is pretty common, about 2 to 3 per 1,000 person year. So 300,000 to 600,000 cases a year, and 60,000 of them will be deaths. So whenever our patients call and say they're having a procedure done, and we're trying to make a decision about whether to start, stop, or do additional anticoagulation, there are a couple of guidelines from the ACCP that has like scoring system. The link below is a calculator showing you can go directly to it, put in all the elements, and it'll count up the points. And then you can kind of put your patient in a categorization. So this chart kind of has the very low, low, moderate, and high risk. And so those would be the risk of having a blood clot without any prophylaxis, like from less than 0.5% up to 6%. And then it depends on what type of surgery they're getting. So if it's like a GI, abdominal, or something neurologic, those have a higher risk. So even though the score is lower, you can see to the right, the recommendation would be mechanical prophylaxis or pharmacologic, like injections or some of the newer oral agents, or in the higher risk to do both. So we don't do this that often. It's not very common that we actually put the numbers in the score and do it, but this just kind of gives you, if you play with the calculator, it gives you a feel for what elements are the most important in putting these patients at risk for a clot. So if they're already on blood thinner and you're trying to decide how long should I hold it in preparation for a procedure, this kind of helps give you a guide. And I really like this chart and the references below. So everybody, even if they have no inherited risk for blood clots, have some risk of having a blood clot, and it goes up with age. And you can see that dotted line is like the threshold for actually having an event. And so people that are born with these congenital thrombophilias, or they're born with the tendency to clot, just theirs is shifted up. So it goes up with age as well. And so that's why when they're 50 or 60 and they have a clot, and they're like, I've never had this before. Why did this just happen? This is kind of the reason why. And if you look on the chart on the right, it shows the same curve, but if you have an event like a surgery or some event, and then you get a clot, that's why. And that'll kind of go into the decision-making for whether it's provoked blood clot or unprovoked. So if it's provoked, you did something to raise your risk, and that risk goes back down again after that event is over. Another just couple of quick things that come up in clinic regularly, or not in clinic, this would be in the hospital. So if the patient comes in, some of the reasons, most people now are using Xarelto and Eliquis, not much warfarin. But one of the issues was like, well, we don't have anything to reverse it. So now, if you didn't stay caught up, there are agents out there. The idarusuzumab is for dabigatran, and then that's Pradaxa. And then there's also the andexanet, which is a reversal agent for both Xarelto and Eliquis. And so the process is, if it's been greater than 8 hours since they took the medication, then you go with low dose. But if they're taking a higher dose of the medication, or if it's been very recent, you may give a little higher dose. So that's how they make the decision. And so you give it as a bolus, and then over 120 minutes, you drip it in. And so these would be those high risk for bleeding, car accident, they're on Xarelto, you're worried about a head bleed in the hospital. We do have these agents for reversal. So if you're talking about you're supposed to have a surgery or something, usually these are not necessary. You just wait. And if you're wondering how long you should wait, so that's another thing I know we get calls about. Okay, they're going to have this procedure done. The patient's on Xarelto. How long should we hold it? So hopefully y'all can get these slides. This is a nice chart. The dabigatran on the left is not one we use as often. I don't use as often, but the abixapam and Xarelto are on the right. And so whether it's a low risk or high risk procedure, and then their creatinine clearance. So the lower their creatinine clearance, the longer you wait. So you can say it's 24 hours, 36, 48. So for these, we don't have to really worry about bridging like you used to for warfarin, because you basically just hold it, have the procedure done, and then go back on it again. So there's no real parenteral bridging necessary. And you can see it says that with low molecular weight heparin. And then after the procedure, you wait 24 hours and you go back on. So these are the risk factors for bleeding and when to do that. So pretty helpful chart. Okay, so I talked a minute ago about provoked versus unprovoked. So generally the recommendation, if there's a provoked, like if you had an abdominal surgery and you got a blood clot, you need 3 months of blood thinner and then you stop it. Or a knee surgery and you get a blood clot in your leg, 3 months and stop it. But if it's unprovoked, if you don't really know why it happened, then the risk is pretty high of it happening again, almost 50% in 5 years. So then you make decisions with the patient, and some of the elements that might help you extend that out closer to a year or longer is if the patient's had a bunch of blood clots before, if it was a pulmonary embolus and not just a small distal DVT. Actually, if you do a D-dimer, like at 3 months, 6 months, or at the end when you're planning to stop it, if it's still elevated, then there is some concern about having a recurrent event, or 4 weeks after stopping it. So those are kind of helpful ways that you can use a D-dimer for risk stratification. And then if a patient has no contraindications for blood thinner, you feel a little more comfortable leaving them on. Or like if they have active cancer or other things, you might want to extend it more. So these are some things that can kind of help you go a little longer, go a little shorter. And if you want to go into more depth, here is a nice paper and the reference is at the bottom. And it goes into this a little more in detail about who would stop or how long you would continue it in that group of patients. And just to say, in the past, for cancer patients, it was always recommended that you use low molecular weight heparin as opposed to warfarin for cancer patients. But the newer anti-10A inhibitors are approved now, and they can be used just as well in cancer patients. So when you have blood clots, even if you have cancer, you can use the Xarelto and the Eliquis. Okay, so the testing for inherited and other forms of thrombophilia, like why did they have the blood clot? So we'll talk about who's going to be tested, and there is some pro and anti-testing issues that I can go over. The reason that there is some anti-testing approaches is because doing tests that you're not going to use the information or may make you do additional testing that's not necessary could actually be harmful at times. And so basically we'll go through both sides of the argument. Okay, so there's many possible inherited reasons to have a blood clot. And in fact, even if you test for all of these and they're all negative, but you have a first-degree relative that has blood clots, yours is, I think, 3 times higher risk of having one. So even if you can't identify the risk, there are probably some that we just don't know how to test for. The most common is factor V Leiden. And so basically, if you're heterozygote, if you have one mutation in this, you have a 3 to 5-fold increase and having a blood clot. Now, your baseline risk for blood clots pretty darn low, so 3 to 5-fold risk isn't huge for most patients. But if you get into a hospitalized patient or one that had surgery, the risk is higher, if you go 3 to 5-fold higher, it can go up quite a bit. It's very, very common. 12% of the population of European descent had this. So if you test everyone, a lot of people are going to have this. Prothrombin gene mutations, another one, pretty common. These two in general have lower risk for clotting in relative terms. The next two, protein C deficiency and protein S, they do have up to 7-fold risk of clotting. So these are a little less common, like 1 in 500 or 1 in 800. So it might make some difference for you in how aggressively to anticoagulate these people. These have a little higher risk of having events, but less common. And then the fifth is the antithrombin deficiency, 1 in 500. It's also considered on the higher end, but these are all relative. In general terms, if you were to just test one of these and for whatever reason you find out it's positive, the patient's never had a blood clot before, you should not put them on blood thinner. It's just information to know for the future, but it doesn't, just because they have the mutation doesn't mean that they're necessarily going to have a blood clot. So those are the big 5 genetic tests that we can do. So if someone has a blood clot, you're trying to decide, should I test them or should I not? These are other tests that we do, anti-phospholipid antibodies. So these are antibodies against the cell surface or the phospholipids or the proteins that bind to them. And these can cause both arterial clots and venous clots. So there's 3 different ones: the lupus anticoagulant, anti-cardiolipin antibody, and anti-beta-2 glycoprotein. And you can see the 3 circles there. You can have 2 of them or 3. And basically, if you have all 3, that's considered triple positive. And those are the highest risk for having recurrent clots. And this is one of the antiphospholipid antibodies, or specifically lupus anticoagulant. If you have it, the lupus anticoagulant test specifically is not always perfect. And you want to repeat it 3 months after the original test to make sure it's still positive. And if it really is positive, this has a high risk of having recurrent clots, and these patients are recommended to stay on lifelong anticoagulation. All right, so here's a clinical presentation. 57-year-old gentleman goes to the emergency room, abdominal pain, has distension, ascites, he has a big liver, his AST and ALT are up, his bilirubin's up, he doesn't drink, he promises, he's no known history of hepatitis, and said this came on really fast. So think about what's your differential in your head for that. Here's his CBC. His white count's 10.5, hemoglobin 17, platelets 600. Think about if you would change your presentation. So this patient has hepatic vein thrombosis, also sometimes called Budd-Chiari syndrome, and it's an obstruction of the flow around the liver. And he had polycythemia vera, at myeloproliferative neoplasm with his elevated hemoglobin. And that put him at risk for this rather atypical type of clot. So these are some atypical types of clots and the things that can be associated with them. So if someone comes in with a hepatic vein thrombosis, you may want to check them out, especially if their blood counts are a little off for this myeloproliferative neoplasm, such as essential thrombocythemia or polycythemia vera, because they're very highly associated. Other ones that are also have these associations are portal vein thrombosis. It also is associated with abdominal cancers and surgeries, so it doesn't have to be this. PNH, or paroxysmal nocturnal hemogolbinuria, is another one that can be associated with these rare types of weird abdominal clots. Mesenteric vein thrombosis, that also is linked to the above. Splenic vein thrombosis is associated oftentimes with things with pancreatic flow for blood flow. So think about pancreatitis or pancreatic malignancy. And then the cerebral or sinus venous thrombosis. These are more common in younger patients. You might want to think about them with birth control pills. And then the final one is when someone has renal vein thrombosis, you want to think about nephrotic syndrome, where patients are spilling protein in their urine. And if someone has a retinal vein thrombosis and they get sent over from the ophthalmologist, there's really no association with acquired or inherited clotting problems. These are more the risk factors for hypertension, diabetes. You don't have to do $1 million workup if someone's sent for that cause. So when you're testing for these myeloproliferative neoplasms, if their hemoglobin's high or platelets are high, these are the tests. You do JAK2, then you can do extended JAK2 testing, CAL-R, and MPL. Those four, that's really 99% of them. And even if their blood counts are normal, but they have these mutations, they are increased risk for hypercoagulability. So sometimes you'll test their hemoglobin, it's high, then it goes back down again. These patients, just for whatever reason, their blood has, it's just more hypercoagulable. So watch out for these weird clots. So for PNH, this is actually a clonal stem cell disorder. You get a mutation, you're not born with it, it develops. And you lose a protein on the surface of your cells, and so they clot and hemolyze more easily. So if the patient has hemolysis, low haptoglobin, high LDH, and it's not a Coombs, and you don't know why, you can send off this test for PNH. It's a flow cytometry test, but if you do regular flow cytometry, it's not going to pick it up. You have to order PNH flow. And sometimes they can have all low counts because everything is being hemolyzed and it's having these off-target effects. So they might have like a pancytopenia. Weird symptoms, just so you know, this smooth muscle dystonia. They can have weird abdominal pain, trouble swallowing, erectile dysfunction. So I don't know if you can remember this weird kind of zebra, but these things can sometimes be from PNH, and it increases your risk of clots. So weird clot and some of these symptoms, think about sending it. And there's a treatment for it, eculizumab. Nephrotic syndrome. So if you lose a gram of protein or more out of your urine because of a kidney problem, that increases your risk of blood clots. And that's because some of those anticoagulant proteins, like protein C and protein S, which are actually, they help you not clot. You lose them as they spill out in your urine, and then your clotting risk goes up. So if you don't have 24 hours to wait, you can do a spot protein to creatinine ratio. So if someone has a low albumin, legs are swollen, and they have a clot, think about nephrotic syndrome. And then homocysteine. So I'll try to be brief. Homocysteinuria is whenever you are born with this difficulty, you make so much homocysteine, it spills out in your urine, and they have increased risk for clots. But patients are often tested for homocysteine levels, or they're tested for this MTHFR mutation, which is very, very common. And it's really hard to know what to do with these when they're sent to you. There has been an association with increased homocysteine levels and clots, but they've never shown by taking folic acid or doing things by lowering it that you can reduce that risk. And it's really, having the mutation is really not an independent factor for clotting. So the only people that you should really worry about this are a very young person with big clots. And that might be someone you want to screen for homocysteinuria. So these MTHFR mutations aren't really helpful. So basically, American Society of Hematology has said 10 things that you should choose wisely not do sometimes. So one is, don't test someone that has a provoked clot, like a surgery, and they have a blood clot. Don't do expensive testing. It's unnecessary. And what they've said is, even if you test them, those with inherited clots and without, the risk of having the next clot is about the same. So it's not going to do any good. These are the risk factors for having another clot, and having an inherited mutation is not one of the predictors of having a recurrent clot. And the second thing they said is, don't do more than 3 months of anticoagulation if it's an uneventful clot. So basically they're saying lots of people they're scared to stop the blood thinner, or they come in and they want to get all kinds of testing. You do all this testing. Does it really help the person, or does it actually cause more problems? So these are the two sides of testing versus not testing. So you have to use your judgment. I have lots of references. Basically, if it's uncomplicated, 3 months, then you stop and don't test them. If it's more complicating factors, you might consider doing additional testing and maybe treating them a bit longer. And then the final slide about COVID. Basically, COVID-19 will affect your blood vessels, and that's why people get so sick. It affects the endothelium. So the risk of a hospitalized patient getting a blood clot when they have COVID-19 is 10 to 15%, and that's up to 20 to 30% in the ICU. There's really no risk supposedly in outpatients. All these patients are going to have an elevated D-dimer, an elevated fibrinogen. So if you check them, they're going to be high. That doesn't mean they necessarily have a clot. What I've been doing is treating these like a provoked. I don't necessarily keep them on lifelong. And because they got COVID, they got a clot, it got better, 3 months and they're done. The only thing is if patients have these vaccine-associated low platelets and clot, if you read about it and people were scared to get them, it was 7 out of 1 million patients for the AZ vaccine and 3 out of 1 million patients for the J&J. Basically, they would make antibodies to their platelets and it would have a weird effect, but it was very, very rare. Well, thank you guys. Sorry, I went a couple minutes over. Hope you have questions for me.